uh, now, and we'll start with hypertension. I just wanted to kind of go over some of the guidelines. And one of the things on hypertension is about every decade guidelines change, and sometimes they change a little bit back and forth. For exam purposes, things that happened a year ago or a year and a half ago, tweaking to guidelines or new guidelines are not going to be the new answer. So trying to go the midline of what's going to be expected. And so, I think the 2017 published guidelines are still pretty mainstream, which are patients without office, daytime blood pressures over 135 systolic, greater than 85 diastolic. Patients without office, blood pressures over 130 or over 80 diastolic, who have multiple risk factors. This is what we've been doing over the last several years based on sprint data, is to be a lot more aggressive in individuals who are at higher risk and really push for lower blood pressures there. Another question that comes up all the time is there an age where it really, intensive therapy may not be a good idea? Can we get that much benefit when people are older? And the answer is yes. This is information from, intensive target benefit summary from Sprint. 34% lower rate of fatal and non-fatal major cardiovascular events in those over 75, a third lower rate of death from any cause, benefits similarly regardless of how frail they are, and cost-effective intensive therapy. It was well tolerated, and the time to benefit was quite short. That's another argument people have as well. If I got an 80-year-old patient and it's going to take 10 or 15 years to see a benefit, they probably won't be alive anyway. The answer is no. That time to benefit can be in under 2 years. So we are more aggressive than we used to be in treatment of blood pressure. A 68-year-old man with hypertension is seen for follow-up. His blood pressure in clinic is 150 over 96, pulse of 80. Blood pressures last year 130 over 80 or less. He gets multiple home readings, which are all over 150 systolic and 90 diastolic. He's got a history of hypertension, depression, prediabetes, a bilateral collarbone fracture 6 weeks ago. Meds are lisinopril 20, chlorthalidone 25. What is the most likely cause for his worsening hypertension? Is now not controlled where we want him. And last year he was right where we want him. He was 130 over 80 or less, which is what we wanted. Now he's 150 over 96. Is it renal artery stenosis, hyperaldosteronism, VFIO, medication use, or Cushing's syndrome? Okay, so 71% of you were right, medication use. And so I think you figured out what he probably got into is an NSAID, that he has this collarbone fracture, very commonly for people to take over-the-counter NSAIDs. They're available. All their friends are saying, hey, you got a broken bone, take an NSAID. And the problem with NSAIDs is they really make ACE inhibitors, ARBs, and diuretics much less effective. So taking big time doses of NSAIDs may negate some of the benefit, if not all the benefit he is getting from his antihypertensive medication. So the common causes of secondary hypertension are sleep apnea, always think of that, NSAID use, other medications, you'll sometimes see it in people on OCPs, venlafaxine, taking medicinal licorice can cause hypertension, recreational drugs, amphetamines and cocaine, and then alcohol. Chronic alcohol use can raise blood pressure, and certainly alcohol withdrawal can raise it in the short term. So these are all common things we see every day, and we're kind of taught secondary hypertension, a list of zebras. These are things that we're going to see and you're going to see regularly. So know these things to be a really good internist, but you may also see the questions around these things on the exam. Here are some of the rarer ones, and when should we think about it? Fibromuscular dysplasia, 90% of the time it's in women. Some have carotid disease as well. probably give you a case where there's a abdominal bruit on an exam in a young woman. That would be a reason to think of this. Renal artery stenosis, these patients have known atherosclerosis elsewhere. They can get flash pulmonary edema, sudden worsening of the renal function with treatment, because if they have bilateral renal artery stenosis and you put them on an ACE, they may get acute renal failure from that. And if you see worsening hypertension in a person who has well-known atherosclerosis, think about this diagnosis. FeO is very rare, but had a combination of hypermetabolism. These people tend to lose weight, tachycardia, sweating, headaches are very common with it. And a pearl that I think could easily be asked would be orthostatic hypotension. You got a really hypertensive person, but their blood pressure drops when they stand up because they have a decreased intravascular volume because of all the catecholamines. Another famous test question is hypertension during procedures and surgery, that they then get hypotension. So they go in hypertensive because they have a decreased vascular volume, they get vasodilated with the anesthetic agents, and now they have severe hypotension. So going from hypertension to hypotension with surgery and anesthesia treatment, you should think about FeO. A 47-year-old woman presents for follow-up of elevated blood pressure. She had a blood pressure of 160/90 at her clinic visit. Her average home blood pressure at 20 readings is 158/92. What do you recommend for treatment? So we feel we got good data here. 20 home blood pressure readings, 158/92. She's 160/90 today at clinic. What do we recommend? Lifestyle modifications, chlorthalidone, lisinopril, metoprolol, or telmisartan amlodipine? Yeah, I think the right answer is E, telmisartan amlodipine. We're not going to get anywhere near where we want to go for target by lifestyle modifications. We're gonna explore that. I mean, if the patient could lose weight, if that's a helpful thing. If they're not exercising, that might drop at 3 or 4 points. If they have a high salt diet, reducing that might drop at 5 points. But we're not going to go from 160/90 down to 130/80 with lifestyle modifications. So I think this is one where you have to read into the question, what's the most effective treatment here? It doesn't mean we wouldn't recommend lifestyle. And if we do single drug therapy and then just kind of crawl it up, it's going to take us a while to get control. So, chlorthalidone and lisinopril are great choices. If you wanted to give chlorthalidone plus lisinopril, that would have been a right answer. I didn't give you that choice. So using the combination therapy because their blood pressure is so high is what we have in all the new guidelines. Lifestyle modifications that have evidence of benefit for hypertension, salt restriction, potassium supplementation, weight loss, DASH diet, limiting alcohol, and doing regular exercise. All of these have positive evidence of benefit for lifestyle modifications. So this is important, and this has been shown in a number of studies, and it's in the most recent accepted guidelines. Initial combination of antihypertensive therapy with 2 first-line agents of different classes is suggested in any patient whose blood pressure is more than 20 milligrams systolic or 10 milligrams diastolic above their goal. So that's what we did here. Now, it's important that you feel comfortable with the blood pressure readings. It's not a single blood pressure reading. Our patient had 20 home readings that were very consistent, and then our in-office blood pressure reading was identical to the home reading, so we feel very comfortable with that. But the person who comes in at 160/90 with one in-clinic reading, we're going to have them collect many home blood pressure readings before we make a decision on treatment and what treatment we're going to do. A 60-year-old woman presents for follow-up of hypertension. She has been taking lisinopril for the last 3 months. Her most recent outside blood pressure readings are 156/94, 150/96, 158/92. Past medical history, type 2 diabetes, GERD, and depression. Meds are lisinopril 20 a day, omeprazole 20 a day, sertraline 50 milligrams a day, and metformin 500 milligrams BID. What do you recommend for this patient. No changes in therapy, increase lisinopril, add metoprolol, or add amlodipine. Okay, you did well on this one too. The right answer here is we need to add another agent here. We're not going to get where we want to go by upping the dose of their one drug. And plenty of lisinopril is pretty darn good blood pressure level, that bumping it up to 40 or giving it twice a day is going to have only a minimal 2 or 3, maybe 4 millimeter mercury benefit, if that. So certainly if you wanted to boost the lisinopril and add amlodipine, that's okay. But many studies now have shown that when we got a sort of an average effective dose of a blood pressure med, escalating the dose isn't going to get us to target. Now, if this patient was only 5 above target, sure, you could try that, but they're not close to that. So doubling the dose or adding the second agent, meta-analysis of 11,000 patients, 42 trials, comparing single dose with up titration, and you can see such a difference here. So you look at when you double the dose, that's the dark bars. The white bars are when you add a drug from another class, and you see this 5-fold reduction in blood pressure compared to just doubling the dose. So the other thing that we got to remember is that 75% of all our patients with hypertension will require combination therapy to get to blood pressure targets. It's a rare patient that just needs one drug. So we know most of our people are going to need 2 drugs. So start with 2 drugs if the patients come in more than 20 systolic high. So we all know thiazides added to an ACE or an ARB is a nice combination, and we usually use low-dose thiazides because they seem to be about as effective as higher doses. The other pearl and trick here is make sure they do salt restriction, because salt restriction will make thiazide diuretic ACE combinations much more potent than if they are not salt restricting. The other pearl about salt restriction is individuals who are eating a lot of salt are going to get more hypokalemic with their diuretics. So when you see terrible hypokalemia with the thiazide diuretic, it may be a bit of a biopsy for either alcohol or salt intake. ACE-amlodipine combination may have cardiovascular benefits slightly better than ACE diuretics in high-risk diabetic patients. There's a large study that suggested that. Just to give you a rough idea of how successful combining an ARB with a diuretic can be, this is a study with an ARB that we don't use in the United States, but I think it gave some pretty good data here, dropping from 30 to 35 points when you do the combination. So you may take a person from 160/90 and get them down to a really nice normal blood pressure with the combination. A 58-year-old man is seen for treatment of hypertension. He has never had good control of his hypertension since treatment started 2 years ago. He's been taking his medications faithfully, and you have evidence from their pharmacy that he's filling it every month. He's taking amlodipine, atenolol, clonidine, and losartan, so he's taking 4 different meds. Blood pressure is 200/106, pulse is 55, BUN is 30, creatinine is 2, sodium is 137, potassium is 4, has LVH on EKG. What do you recommend? Increases amlodipine from 10 a day to 10 twice a day, increases losartan from 50 BID to 100 BID, add hydrochlorothiazide 12.5 a day, add hydrochlorothiazide 25 a day, or add furosemide 40 milligrams BID. So this case was to remind you, in people who have chronic kidney disease and have low GFRs, thiazide diuretics are not the best choice. They increase the risk of gout, and they may not be as efficacious as they are in people with normal GFRs. So in that group of patients, we would add furosemide. And this is the rare time we use furosemide as a blood pressure med, because this person probably has significant volume dependent hypertension. And the one thing we really haven't tried is really trying to unload them with furosemide. So because furosemide has such a short half-life, it's going to need to be dosed twice a day. So the folks in nephrology clinics, this is a standard go-to drug they use in these patients who have chronic kidney disease, getting them on a loop diuretic to see if this will help with their blood pressure. Now, it may not. This person may be in a lot of trouble in managing their hypertension. We may have to do other things. And but I would, because they're not on a diuretic, I would do this to see if we just really hit a home run here, and would use a loop diuretic instead of hydrochlorothiazide. So some of the most common causes of resistant hypertension is non-adherence. It is the cause for the vast majority of patients. When you have somebody on 4-drug therapy and their pressures are terrible, they're 180, 170, 200, the vast majority of those people are not going to be taking their meds. If you look at this study, this patient looks at patients referred for renal denervation. They were desperate. No med ever worked for these people for refractory or resistant hypertension. Blood levels were measured of antihypertensive drugs, and they wanted to be sure they were taking them before they did an invasive, dangerous procedure. These patients knew they were going to have their blood levels, and 80% of them, fewer meds were detected than prescribed. So 8 out of 10 of these patients with horrible, horrible hypertension are not taking everything we prescribe. So be aware that's the first thing we're going to always look at, and we're going to really have that really face-to-face serious talk with them, because I always say, before I put you on something that could really make you sick, I got to make sure that you're taking every pill I'm prescribing. And there's no shame if you aren't. I just want to know it, because I want to be doing the right thing. I don't want to be doing the wrong thing. A 55-year-old woman presents with persistent hypertension. She has been taking chlorthalidone, lisinopril, amlodipine, and metoprolol. Blood pressure today is 158/96. Outside readings are similar, all over up around 160. And we have that heart-to-heart talk with her and say, are you taking your chlorthalidone, lisinopril, amlodipine, and metoprolol? And she says yes. And we call the pharmacy, and the pharmacy says they're being filled. And then we say, they're being filled every month. Are you taking them every month? And she says, doctor, don't you trust me? And you say, I trust you, but I know it's hard, because 8 out of 10 people don't do it. And she said, her son comes in from the waiting room and says, no, mom's taking every med. I promise you she is. So you accept that. Now we move forward. Labs show sodium 134, potassium 4.2, BUN of 12, creatinine of 1. What do you recommend? What's the next thing to do here? Replace chlorthalidone with furosemide, add diltiazem, add clonidine, add spironolactone, or switch amlodipine to minoxidil. Yes, we want to add spironolactone. It's a miracle drug for resistant hypertension, or the people that aren't responding to what we're giving them. It's really, in all the guidelines, is sort of our go-to after we've started the big three, after we got people on amlodipine, an ACE or an ARB, and a diuretic. We move on to spironolactone. Primary hyperaldosteronism is the most common cause of secondary hypertension in hypertension clinics. Up to a quarter of patients, it's present in 5 to 10% of patients with hypertension. Over 50% of patients do not have hypokalemia. That's what we always were taught. I was certainly taught, look at their labs when they're not on meds and they're all going to be hypokalemic. Not true. So over half don't have it. Classic board presentation of a patient who had primary hyperaldosteronism would be hypertension, hypokalemia, and alkalosis. And then the workup, plasma renin activity and aldosterone concentration, CT scan in patients who have a positive result to see if they have bilateral adrenal hyperplasia. Now, this is sort of the perfect workup. Reality in real world is we treat these people with spironolactone, and when their blood pressure normalizes, it's pretty much giving you the positive workup. Here's studies that show how remarkably effective it is just giving everybody spironolactone when they have refractory hypertension. Average blood pressure reduction was 17 to 20 systolic, 4 to 9 diastolic, with largest reduction seen in patients who had a systolic blood pressure over 150 at baseline. In a study of 175 patients with refractory hypertension on a mean of 4 blood pressure meds, addition of spironolactone resulted in lowering blood pressure by an average of 16 systolic, 9 diastolic, with about half of the patients on medication achieving a goal of blood pressure under 140/90. So these are the worst of the worst. Nothing works, and we can drop their blood pressure by 15/10. That's pretty darn good. This is just a study that shows if you actually measure how aldosterone levels in these people, the more drugs they're on, the higher their aldosterone level. A 64-year-old woman presents for follow-up. She has had a past medical history of osteopenia with the T-score minus 2.3 at the hip and GERD, and has had 3 outside blood pressure readings, 160/90, 158/88, and 164/92. Today in clinic, her blood pressure is 158/86. Her blood pressure a year ago was 154/88. Her meds are omeprazole and vitamin D. Which would be the best treatment recommendation for her? So she has blood pressure 160/90, 158/88, 164/92. So she's got high blood pressure and she's taking omeprazole and vitamin D. She has osteopenia. What would be the best treatment? Now, I told you already you should put her on 2 drugs. So what I'm asking you here is which of these drugs may be the most beneficial for her globally, not just for her blood pressure. So chlorthalidone, lisinopril, metoprolol, and diltiazem. I'm going to take monitor blood pressure, no therapy off because that doesn't make sense given how high blood pressures are. So the right answer here is chlorthalidone, and it doesn't mean that we're only going to give her chlorthalidone, but we really would like to do that because of her bone density. The fact she has osteopenia, thiazide and thiazide-like diuretics like chlorthalidone increase serum calcium, and they can potentially increase bone density and decrease fracture risk. Meta-analysis of 5 trials, 756 patients. Serum calcium levels are higher in those in thiazide with a difference of 0.33. Urinary calcium excretion is lower in patients on thiazides. You know that because we use them in some patients with kidney stones. But more importantly do they have a reduction in hip fracture risk? This is looking at 11 different cohort studies, 2 million patients. Thiazide diuretic users and compared to non-users had a 14% reduction in risk of all fractures and an 18% reduction in hip fracture risk. This hip fracture risk lasted as long as they were on their thiazide diuretic. So it's a nice add-on to your patients who have osteoporosis who you need to treat blood pressure. I love thiazide and thiazide-like diuretics in this population because I get a 2 for it. A 48-year-old woman with hypertension presents for annual follow-up. Her last lipids were checked 5 years ago. We're now moving into lipid issues with the total cholesterol 190, LDL, I think it's 165, HDL 45, triglycerides 100, meds nifedipine and chlorthalidone. Her exam, blood pressure 140/60, pulse is 80, chest is clear, cardiac normal S1, S2, 2 plus peripheral edema, total cholesterol 255, LDL 170, HDL 40, triglycerides 160. What is appropriate next step? Start pravastatin, start atorvastatin, start ezetimibe, check a CMP, UA, and TSH, check a BMP and estrogen. So I'm sorry, her LDL was 125 5 years ago. Now it's 170. So yes, we should at least do before we start treating her, and she will need treatment very likely, but we should also look and try to understand why her LDL went up so much. That's a pretty huge jump in the LDL over a few year period. And we want to make sure if we haven't done labs recently, we want to look at renal function. We want to make sure she doesn't have nephrotic syndrome. We want to make sure she doesn't have hypothyroidism. Very likely that these are going to come back normal. But before we just jump into treatment arm for lipids, we want to see if she has developed a disease that has raised her lipids. So when we think about secondary hyperlipidemia, increased LDL can occur with hypothyroidism, nephrotic syndrome, and cholestatic liver disease. A 61-year-old man with hyperlipidemia, type 2 diabetes, and a family history of early MI had a hospitalization for unstable angina and received coronary stent last week. He is taking 40 apravastatin, clopidogrel, aspirin, and metformin. Labs, A1C of 6.5%, total cholesterol 210, HDL 45, LDL 119, triglyceride 183. What is the most appropriate treatment? Bump his pravastatin to 80, put him on 80 of atorvastatin, 80 of atorvastatin, and 1,000 of niacin or 1,000 of niacin. Yeah, this person needs a high intensity, high dose statin. He has known coronary disease, and he's been on pravastatin, which may have been an initially started because of risks and primary prevention, which is fine to use pravastatin for that. But when a person has known coronary disease, and this patient was hospitalized for unstable angina and had a stent, we're going to put him on high intensity statin at a high dose. Really no use for niacin in any way, shape, or form in 2026. A 70-year-old woman presents her primary care visit. She has no symptoms, past medical history, hypertension, GERD, and a non-smoker, blood pressure 120 over 70, pulse 66, hemoglobin A1C 5.2, BUN 10, creatinine 1.1, total cholesterol 190, LDL 135, HDL 42. What do you recommend for her? Diet and exercise, recheck cholesterol, fenofibrate, pravastatin 40, atorvastatin 80, or no intervention. So she's 70 with a history of hypertension and GERD. Blood pressure is 120 over 70, so well controlled on her blood pressure treatment. A1C is fine. Her LDL is 135. Yeah, so this patient I would put on pravastatin. This is a patient who's got hypertension. Her age and her hypertension is going to get her 10-year cardiovascular risk up into the treatment realm. I mean, we don't have if we don't have our calculators available for us, uh, then we need to kind of just know that a risk factor plus age is going to put her in the group that gets treated. So at that point, she'd be getting primary prevention. The pravastatin would be totally fine to do that. So using the AHA cardiac risk calculator, risk of MI and stroke, 11.5% over the next 10 years. So a low to moderate intensity statin like pravastatin at 40 would be fine. So just in general, if somebody's over 65 and have one or more risk factors, they'll have over a 7.5% risk over 10 years. So just that alone, regardless of what the cholesterol is going to be, you're going to get over 7.5. And that's kind of the break point for at least if you use the AHA guidelines. The U.S. Preventive Task Force likes 10. This person had a high enough lipid that it even makes the AHA guidelines. So U.S. Preventive Task Force recommends low to moderate dose statins in people 40 to 75 without a history of cardiovascular disease who have one or more risk factors and a calculated 10-year cardiovascular risk over 10%. That's what this patient had. While undergoing evaluation for hysterectomy, a 50-year-old is noted to have total cholesterol 245, HDL 56, triglycerides 645. She has an A1C of 5.6, past medical history, migraine, hypertension. Her exam is normal, and her medications include propranolol, hydrochlorothiazide, and an oral estrogen. What do you recommend? Remember, her triglycerides are 646. No change in therapy. Add niacin, add gemfibrozil, replace propranolol and oral estrogen. So she has a triglyceride that's getting up there, well over 600. We generally ignore low elevated ones, ones in the 200 range. I have all my patients charting me, didn't do fasting lipids, and they're like, my lipids, my triglycerides 170. What should we be doing about it? It's like, well, we'll have you fast next time if it makes you nervous to see a triglyceride of 170. But when it gets over 500, 600, we usually take notice. And in this patient, I don't know why she's on propranolol, probably because she had a physician from the 70s or something, and they put her on a beta blocker that she may not need. Maybe it was for migraine prophylaxis, but now that she's been on estrogen for a while, probably isn't going to need the propranolol. Um, so getting her off propranolol, switching her maybe to a transdermal estrogen would probably bring the triglycerides down nicely. So recognize that this is likely a medication-induced issue, and that this is one that you can probably get into a much better range by just tweaking her medication regimen. So moderate elevation, 300 to 800, non-fasting state, medications like estrogens, beta blockers, protease inhibitors, Accutane, clozapine, olanzapine, hypothyroidism, insulin resistance. When you get over 855, you see these familial hypertriglyceridemias, and then the medicines that are just bad actors like clozapine, olanzapine, protease inhibitors. The highest triglyceride I've ever seen was a patient that I treated with full dose ritonavir back when that was a thing in the mid 90s, when I had him on doses we'd never used, but I did get his triglycerides up to 6,500 and gave him pancreatitis. So you can do this with certain medications. So what about bile acid sequestrants? The answer is we don't use them for lipids. There really is no reason to use them. We used to combine them with statins. Some patients don't like them. I think bile acid sequestrants are my go-to meds for bile acid diarrhea. My patients who have diarrhea after they have a cholecystectomy, they love their cholestyramine, but we can do much better with other drugs like ezetimibe. And if the patient has severe LDL elevation and we need other treatments beyond statins, we have other effective agents. Niacin, absolutely no role. It can lower LDL, it can raise HDL, it can lower triglycerides. Sounds great, but it's hard to take. People get flushing, they get gout, they can get hepatotoxicity, and there was no benefit on mortality. And with the studies where we saw that, we really got away from using it. So really no role for niacin. Niacin is just going to be a distractor on any question you get. Fibrates, they can lower triglycerides by half, slightly raise HDL. Fenofibrate is probably the best one to use because it has less drug interactions with statins. Gemfibrozil has drug interactions with statins, but we use a lot of fenofibrate in our statin patients who have really, really high triglycerides. And it's used as a solo agent if they only have a very high triglyceride. People with familial hypertriglyceridemia, individuals who are running 1,000, yes, we'll use fenofibrate. And I rarely ever use gemfibrozil because the fenofibrate's a little safer with other drugs. A couple of words on fatty acids. Icosapent is a prescription fatty acid, and it's been studied, does lower triglycerides, and has been used in people with the very highest cardiovascular risk and has some efficacy in that group. Using omega-3 fatty acids, just over-the-counter stuff in patients without cardiovascular risk, there's a lot more controversy in that, and just using sort of over-the-counter stuff, we're not sure it offers that much benefit. And there has been some data on increased atrial fibrillation risk with this. This is still being worked out. A couple of meta-analyses have been positive for that. Certainly, if I have a patient in AFib who's taking uh, fatty acids, I'll remove it. I am not sure what I should counsel other patients other than I don't find much benefit in the average risk patient of just taking a fatty omega-3 fatty acid because it's good for them. They think it's good for them. I do think that eating diet with regular fish oils in it is good for people, and there's good evidence for that. A 68-year-old man presents for follow-up after recent MI. He's had 4 prior MIs over the past 12 years. He has had a 3-vessel CABG and 2 stents placed, so this is your highest of highest risk patients. He quit smoking after his first MI 12 years ago. Blood pressure ranges between 110 and 130, systolic 50 and 60, 55 to 65 diastolic. He's on irbesartan, aspirin, atorvastatin 80, ezetimibe 10, labs, total cholesterol 150, HDL 36, LDL 78, triglycerides 200. What is the best treatment to reduce his risk for reinfarction? Add chlorthalidone, add niacin, add evolocumab, add fenofibrate. Yeah, this is a great candidate for evolocumab. He's had more MIs. He's on a high dose statin. Uh, he doesn't have the best lipid profile for somebody on a high dose statin. He's 78 with continued reinfarction. I think all our cardiologists would like him as low as you could go with this pattern of 4 prior MIs and 2 stents. Certainly under LDL of 70 would be a minimum. I think trying to get them under 50 would be a good thing. So I think definitely niacin doesn't have mortality benefit. Fenofibrate, maybe you're going to raise the HDL a little bit, but all the data is going to be with using the volcamab. That's going to be the better option. So PCSK9 inhibitors, indications, homozygous, heterozygous familial hypercholesterolemia, patients who are our highest risk who cannot take statins for a well-documented reason. I will tell you, and some of you have this experience, they need to have failed multiple statins and show that they're intolerant to several different statins. They won't just give it the first time they have statin intolerance. And then the very high-risk patients where they're unable to get LDLs less than 70 with maximum statin ezetimibe. A 66-year-old woman is discharged from the hospital after an MI. Her discharge medications include atorvastatin 40, lisinopril 20, aspirin 81, and clopidogrel 75. At her follow-up appointment, she mentions that she has muscle pain and stiffness in both her legs and her back. TSH is 2, vitamin D level is normal. She stops atorvastatin for 2 weeks with resolution of her symptoms. So we have somebody who was just diagnosed with an MI and started on a statin. She started to hurt. She went on the internet, saw that statins could be associated with muscle pain. So without talking to you, she stops her atorvastatin for 2 weeks and says, hey, I don't hurt anymore. What do we recommend now? Restart her atorvastatin, start rosuvastatin twice a week, start ezetimibe, or start a PCSK9 inhibitor. So I think the right answer here is A, restart or atorvastatin. Now, it's not going to be easy because she's going to say, I told you that it causes pain. And what you're going to do is share some of the data I'm going to present in a second with her. And part of the problem on D, if you want to go to D, it's not going to be covered when you've done no statin dance for the insurance companies. So there is some pretty good data on re-challenge. And there's also data on, it's very possible that what she had was a nocebo effect. She got on the internet very quickly. She may have seen that there was pain, and then she's attributing it to the statin. How big is this? Well, it's a huge effect. This is an incredible study of 60 patients who had a history of statin-associated muscle symptoms, and they were given 4 bottles containing atorvastatin, 4 bottles containing placebo, and 4 empty bottles. Each bottle was used for 1 month according to random sequence. And then they asked them to track their symptoms over the entirety of the year. So you could see, did they have more symptoms when they got statin, when they took placebo, or when they had an empty bottle? And when they had the empty bottle months, they had a symptom intensity of 8. So that was really good. When they took placebo, it jumped up to 15.4, and when they took atorvastatin, it was 16.3. So no statistical difference between atorvastatin and placebo, but a big difference between taking an empty bottle month. So this has been a lot of the driver behind trying to coach our patients to be brave and keep giving statins a chance as we play the statin shell game with them. This is another study looking at re-challenge, where what if we just give them what if we just re-challenge them? This is a retrospective study of 118 patients referred to a lipid clinic as being statin intolerant. So they've already been proven to have symptoms on 2 or more statins. The patients were either re-challenged with the same statin, a different statin they hadn't received before, or given ezetimibe. Tolerability was the most when you just gave them back their old statin, 53% when you switched their statin, and 57% was ezetimibe. So there's this nocebo effect, and so it's just as good to just give them back their same statin, and maybe it's a little better. At least it's just as good. So that's why the right answer here was just try the atorvastatin again with a little bit of counseling. So what should be our approach to management of myalgias on statins? Check a CK, TSH, vitamin D, review for drug interactions, especially calcium channel blockers. They can double and triple the area under the curve. So if somebody is on verapamil or diltiazem for rate control of AFib, and then you start atorvastatin, they might get toxicity because you're giving them super physiologic doses of atorvastatin. After you've cleared that they have a normal CK, a normal TSH, and normal vitamin D, the reason we get the TSH is 2 reasons. One, hypothyroidism can cause muscle aches, but more importantly, there are studies that show that hypothyroid individuals have more muscle symptoms on statins, so we check that first. Once we assure that it isn't a drug interaction or a problem with true rhabdomyolysis, hypothyroidism, or hypovitaminosis D, we'll stop the statin. When symptoms disappear, restart the statin at a lower dose. That's reasonable. Just re-challenge them or start at a lower dose, or change the statin. So I'll start with re-challenge. If that doesn't work, I'll change the statin. Then if you've changed to rosuvastatin and that they have trouble there, then you can try a third statin. Maybe you try pitavastatin. Then you can switch to intermittent potent statin. Now, the problem with doing that is if the patient has known coronary disease, we have no outcome data. We have data on they can tolerate the statin, but we don't know if two or 3 times a week rosuvastatin is enough to protect their fragile coronary arteries. We don't know if it stabilizes their arteries. And then if that doesn't work, ezetimibe or a PCSK9 inhibitor, my highest risk patients, by this time, I've done enough placating the insurance company to get them on the PCSK9 inhibitor. A quick word on bempedoic acid, another option in statin intolerant patients. This is a study, 13,970 statin intolerant patients enrolled in a double-blind randomized placebo-controlled study, randomized to bempedoic acid or placebo. Incidence of primary endpoint event was significantly lower with bempedoic acid than placebo, as were the incidence composite of death from cardiovascular causes, non-fatal stroke or non-fatal myocardial infarctions. So a little bit of a drop in the hazard ratio, but at least this shows that we're getting what we want. It's not just lowering lipids, but we're getting endpoints. Just be aware of the side effects. I could see that you could get tested on this. Increases uric acid level in gout, increases gallstones, and then the black box warning talks about tendon rupture, although the expanded access does not show tendon rupture, but it's still a warning. So Gout in 3.1% versus 2.1%. Increased cholelithiasis 2.1 versus 1.1. And then the black box warning still talks about tendon rupture. So we'll stop there. Let's give you a let's go with a 10-minute break here, since you've been so patient and sitting for so long. We'll start again at 5:20, and I promise we'll finish before 6:15.